Yeah, psychology degree at Concordia University in Montreal, and then I went to New York University to do a doctoral degree in clinical social psychology, clinical community psychology, and then from there I went to work at Bellevue Psychiatric Hospital. It's one of New York City's large urban hospitals that has a long history of treating people with severe mental illness. Homelessness started in America around the 1980s, and I was working at the hospital at the time. And I was living close to the hospital, walking distance. And on my way home or to the hospital, I started seeing people on the streets that had been in treatment in the hospital, that I knew from the hospital. And that's when I left the job of the inpatient service and took a job working on the streets of New York City to work with people who were mentally ill but on the street. Well, the seed of the solution was born out of repeated failures in an existing system that required people who were on the street and who were suffering from psychiatric symptoms and sometimes from addiction or health problems to essentially cure those problems in order to get into housing. The existing housing provider community was very nervous about admitting people who were actively symptomatic or actively using, and they wanted tenants that would be reliable, that would be well behaved, if you will. So the group that I was working with on the street had virtually no chance of getting into those places. And what would happen is they would get sick, they would go to the hospital, or they would get arrested and go to jail, and then end up back on the street, sometimes in the same spot where we had met them. And that repeated cycle, seeing that over and over again, created a kind of a desperation to do something different, because what we had in place and what we were doing wasn't working. The way we derived a better solution than what was in place really had a couple of different steps to it. The first step was the realization that what we knew in terms of us as experts was not sufficient to solve the problem. And so the first part of finding a solution was to include in the conversation about the problem the people we were actually working with, the people on the street. We've tried taking you to the hospital. We've tried getting you into these programs. We've tried getting you into a alcohol or drug treatment program, and it hasn't worked. What can we do differently? You tell us what would work for you. And the person would say, isn't it obvious? I need a place to live. And as strange as that may sound, because it's so painfully obvious, that was not a route available to them. The only way into housing was through treatment first and then housing. So having realized that the solution was about direct access to housing, step two was to create a vehicle for providing that service, create an agency, Pathways to Housing, get a grant that had money for rent and support services, and then go back to those people on the street and offer them what they wanted most, a place to live. While that seemed obvious and simple, it had not really been done before. Taking someone on the street that was visibly using or symptomatic and giving them the opportunity that they were desperate for, asking for, a place of their own to live, required a suspension of our own anxieties and our own sense of we're liable, you know, what's going to happen, because it was a different level of risk, you know, a level of risk that certainly the hospital system wouldn't take, and certainly many housing providers or other programs don't take. Programs like a lot of control, especially with things that they're afraid of or don't understand, like mental illness. So it does require that you suppress your anxiety and you allow the person an opportunity to live in an apartment. We didn't know how that would turn out. We didn't know how it would turn out for the person we were bringing into the apartment, And because we were renting from the private market, there were other individuals, families, old people, young people there, kids. And so it was, fingers crossed, we're going to let this person have a shot at housing. And we were very diligent about visiting. I mean, it's housing first, but it's not housing only. There's a lot of support in this program, and the support is in the form of a visit from one of the staff, especially in the beginning, the first weeks, every day. How are you doing? Everything okay? How's it working out for you? So there was a real, to manage our own anxiety and to support the person. Both. We saw them a lot. It worked out spectacularly well. I mean, much to our surprise, frankly, we didn't know people were that capable, because here's the thing about rough sleeping. And I think this is sort of the counterintuitive piece of housing first. When you typically walk by a person on the street, and especially if the person has a psychiatric problem or is severely addicted, maybe just zoned out because they've just shot up, injected, and you think, no way, this person can manage an apartment of their own. Because of that quick snapshot, because we're walking by, mostly averting our eyes, not really wanting to see or feel the pain. And so we think, no way. But if you think about it, over time, people who are on the street, existing on the street, are not only surviving street life on a daily basis, they know where to eat, they know where they can go to the bathroom, they know where to leave their stuff, they know who to trust. They're managing a life with nothing. So they are remarkably resourceful and resilient and creative. So taking the person who's been managing a life on the street and putting them into an apartment actually is much, much easier for them than we ever thought. We just didn't think of it in those terms. The service part unfolds differently for different people. Some people start to feel the aches and pains that they had been kind of keeping at bay while they were homeless, and they want to see a doctor. Other people desperately want to get in touch with their family that they've lost touch with. Some people, after a very short time, want something to do. This is great, I have this apartment, but I need a job. I need something to fill my time with. So the course of the person's journey after they're housed is as unique as the individuals we house. But everybody wants to do something different, and the support services are flexible so that we will follow their motivation. We will follow their desires. We don't have an agenda like, oh, now you're housed, now let's get you to treatment, or let's get you to detox, or let's get you to work. We are here to support you to find your own way. Because what we're working on there is self-determination. It's what everybody wants. Everyone wants to have people managing their own lives, right? With some support in some cases. But how you build self-determination and effectiveness is not by having a program with a bunch of rules that people follow. That builds compliance and conformity. And then somehow we're expecting people to be self-determining, independent. In this program, right from the street, we don't say, listen, you're going to go into an apartment. We say, how can I help you? The person's driving from the start. I want a place to live. This is great. I want to connect with my family. All the better. We're going to help you with that. I want a job. Can you help me with that? Yes. So what is going on dynamically is the person is asserting and achieving their goals one by one, feeling more confident, feeling more a sense of mastery about what they can accomplish. When you break down homelessness in terms of service utilization costs, someone who's homeless for a long time could rack up literally hundreds of thousands of dollars a year in services, still not be well served by them, and still be homeless. By contrast, if you put a person like that in an apartment, paying some subsidy for the rent and having a support team, social work, maybe nursing, visit and support them, The cost of that is somewhere around $20,000, $25,000 a year per person for the whole thing, versus $100,000 or $150,000 in services with no result if you leave a person homeless. So homelessness is neither cheap or without, not only the financial costs, but the quality of life costs for the person who's homeless and for the rest of the members of the community. We're paying an enormous price for homelessness. And this thing is not only an effective solution, but it saves money to the taxpayer. One of the misunderstandings about root causes of homelessness is that people think that because they see someone who has these multiple problems on the street, they think, oh, there's something about that person. It must be their addiction, or it must be they're not taking their medication. That's why they're on the street. A kind of individual attribution to the homelessness. But there's a different interpretation to that, which is the rents are going up. People who have disabilities or are very poor get some fixed amount of money from the government. That amount of money, if you have the misfortune of losing your family or your support, or you end up homeless in some way, and if you're on a government benefit, which most people with disabilities are, there is no way that you can afford to have the month's rent and security deposit to get back into housing. You're priced out of the rental market. So people who are homeless are not there because they've made bad choices. They're there because they're desperately poor, and the benefits afforded to them are nowhere close to be able to allow them to get back into the market. Solving the problem of rough sleeping, homelessness, is a good way for a community to begin. The solution to homelessness will begin to point the road to all the problems that need to be fixed in the larger context of people falling into poverty. So homelessness is just the tip of the iceberg of people who are not earning enough to pay rent, wages being too low, rents being too high. There are structural problems that New Zealand is heading head on into that will continue to contribute to homelessness. Taking care of people who are chronically homeless will do two things. It'll demonstrate that you can solve this problem, and it'll also create more capacity in existing programs where this small group of rough sleepers is typically using up more than half of the resources of any one agency. So it will free up a flow in the system so that more people can be served. And you need that because more people are going to enter homelessness, but hopefully they'll be in and out in a short time rather than being in it for years. I'm here to share the experience I've had in ending chronic homelessness in other cities throughout the United States. And I can tell you that taking a housing-first approach, targeting people who are chronically homeless with multiple problems as a starting point, changing the system so it moves more towards a housing-first approach rather than let's improve people for housing approach, has resulted in ending chronic homelessness in Salt Lake City. It's ended veterans homelessness in New Orleans, etc. Veterans homelessness ended in Houston. Reduction in chronic homelessness in other cities as well. So it's an evidence-based solution I'm bringing. It's not a theoretical solution. It's one of experience and data. In the short time that I've been here in New Zealand, I've learned a couple of things. I've learned that the problem with rough sleepers is totally manageable. That there's a number that is finite and can be housed. There are organizations in place, Lifewise. It's got a cafe, it's got the right philosophical mindset, it's got the right approach to homelessness, that they could start a program like Housing First and solve this thing in 2 years. You don't need a 10-year plan to end homelessness. This isn't New York City where there are 50,000 people showing up at the shelters every night. This is a nipping a problem in the bud by doing the right thing now.